Good job, Julie.
Good morning. How many we got? 2, 4, 16 per page. Three pages.
Good morning to the communities of Grenada and Scott Valley, and welcome, Dr. Stutz.
Got to unmute first. Hi, I'm Ginger Lee Charles. I'm the principal superintendent at the Grenada Elementary School District.
And I'm Micheline Miglis, superintendent of the Scott Valley Unified School District.
Micheline and I are going to co-host and moderate this Q&A session with Dr. Stutz. We appreciate everyone's schedule and attentiveness to the topics. Thank you very much, Dr. Stutz, for your prompt willingness to meet with us and for your ongoing responsiveness to our priority to keep our students in school and safe.
I'll take care of a few logistics before we dive in. The session is being recorded and will be made available for viewing at a later date. Guests joining will have the opportunity to hear the moderated conversation. Guests will need to submit questions or comments via the chat feature to either Ginger Lee or to me, and we will in turn present them to Dr. Stutz. That's an effort to help save us some time. I understand, and I actually do see some of our wonderful students joining from Etna High School. Good morning to the students and teachers in the classroom and or the Scott River High School. Great to see you guys. And I want to acknowledge their civic interest and their desire to learn more. With that, let's get started. Good morning, Dr. Stutz. Again, thank you so much for being here. Will you briefly share with us the governor's vaccination plan, and also please help us understand what it takes to get a vaccine approved by the Federal Drug Administration?
Yeah, so can you guys hear me okay?
Yes.
All right.
Yes.
So the vaccine plan is pretty complex. It's like a 25-page document. I can kind of summarize it for you guys, but what I am going to do is I'm going to put the link to that chat box here, and maybe one of you guys could just forward it to people. But so let me just do that. Essentially, this plan is, everybody asks about Governor Newsom this, Governor Newsom that. I mean, Governor Newsom isn't in charge of the pandemic response in California, okay? It's CDPH, California. So when we hear of, about new rules coming out or guidelines or things like that, yeah, I'm sure that they ran them by Governor Newsom, and his team. These things rests with the state health officer, and that person is Thomas Aragon right now, as well as the health officers of all of the counties like me. So it's not really Governor Newsom has a plan, but he's not a physician, right? And he's not a health officer. So he's not really in charge of this pandemic response. He's in charge of some parts of it, right? Like the finances and some logistical things and regulations and things like that in conjunction with the health officers. So I would say that, just reading from his plan right now, the main focus is to do outreach for vaccinations and try to get unvaccinated parts of our community vaccinated. And that includes addressing equity gaps, like for rural counties such as ours, or certain parts of our population who are underserved. So they're really heavily focusing on that right now, as well as ensuring that they have enough capacity, enough vaccine on hand to meet that demand. And then right now it's to vaccinate children under age 12 if and when they become available. So that's just the very top of his plan that I have on my desktop right now. But the plan is 25 pages long. Essentially, it's to provide funding for vaccination around the state and various forms of grants and things like that. As well as logistical support to the local health departments to support vaccination efforts. And then there's a huge push to combat misinformation about the vaccine at the statewide level, because we've been fighting a lot of misinformation about the vaccine's efficacy and safety since it came out. So that's part of this plan as well.
Thank you.
Thank you, Dr. Stutz. Once the vaccine is approved, do you know the steps that follow before actually requiring the vaccine? And can you talk about the 2 phases based on the different age groups of students?
Yeah, so actually, let me see. Am I able to share my screen? Can you guys?
I can give you permission. Let's
Yeah.
see.
So I have a PowerPoint that I had been using for some of my talks. It has a little bit of a graphic on it for how the vaccine gets approved. Let me see if I can show that to you guys.
Will you try? Yes. Okay.
Okay, can you see that?
Yes.
Yes.
All right. So this is the basic process for how a vaccine gets developed, at least scientifically, right? There's a lot of steps in here, and the development in labs, the clinical trials, the evaluation and decision part is what I suppose the question is aimed at. In here, the evaluation and decision of the data, is it safe for people? Can we recommend it, on an FDA, on a nationwide level, a state level? So it's that 4th step there that I think you're talking about. So I'm going to go to this slide. Can you see that slide?
Yes.
So this is how it gets approved, at least on a federal level, right? So the development and testing happens first. There's 3 phases of clinical trials, and once they have enough data, and that happened last year, right? So early on last year, those clinical trials all happened, and they had about 40,000 participants in the Pfizer trial, and they had about 44,000 or something in the Moderna. And once they had collected enough data for efficacy and safety that met criteria for the FDA, they submitted it to the FDA biologics licensing application, right, for emergency use authorization. So emergency use authorization is only to be used in a case where there's an immediate need for a therapeutic that's demonstrated to have efficacy and safety, but it hasn't met all the criteria for full approval yet. So we need to get it out fast, because there are people who could die who don't, right? So that's what the EUA process is for. So they submitted data good enough to meet the EUA process to the FDA. The VRBPAC, the Vaccines and Related Biologic Products Advisory Committee, is the part of the FDA that decides if the data is good enough. does it work well enough? Is it safe enough? And can we give it emergency use or final authorization, right? So that's a committee that's made up of experienced physicians, clinicians, and oftentimes medical researchers, right? People with PhDs who do research, but who treat patients as well, right? And if they decide the data is good enough, then the FDA will approve it for use for certain indications, right? For use to prevent COVID, right? So, but it doesn't really tell physicians or the community how to use it, right? Who should we use it in? What dose should we give? That sort of a thing. So from there, it goes on to the ACIP, the Advisory Committee on Immunization Practices of the CDC, right? And the CDC looks it over and says, okay, it's safe and effective. Here are the guidelines under which it should be used. These age groups, this dose, right? This frequency. And so that's how that works. And then the CDC puts its stamp of approval on it, the ACIP, right? And then special for the COVID pandemic, right? The Western states decided to make to review the data and make their own guidelines and recommendations. And so here in California, we also have an additional step where we have a panel of experts review the data, safety, efficacy, guidelines from the CDC, and put our stamp of approval on it, and sometimes make some modifications to those recommendations. And then and only then is it approved either for EUA or final approval, right? Does that explain the kind of the process? And so essentially, this recent statewide mandate that students and teachers must be vaccinated by certain dates and times, it all has to go through this process first for final approval. So not just emergency use authorization, it actually has to be approved for use in those kids and those teachers, right? Before requiring it to go to school or to go to work if you work at a school. So it has to go through all those steps first. That's not even close to happening for kids. That's probably going to happen early next year sometime. We haven't even gotten emergency use authorization approval for children 5 to 11, right? So the only company that's even submitted data to the FDA for emergency use for that age group is Pfizer, and they submitted it recently, like in the last couple of weeks. It's going to take a while to get through that EUA process, and then it's going to take another long while for it to get through the full approval process, right? So you saw how long it took us to get full approval for adults. We're a year out now from emergency use authorization, and just recently, like last month, did we get full approval for the vaccine, right? So it's going to be a while until we get full approval for kids.
Okay. Thank you very much.
Great. So just for clarification then, and perhaps a follow-up, what I hear you saying is that after the emergency use approval, then there's a final approval, and your timeline at this point in time seems to sound like that would happen early next year.
Yeah, that's my assumption right now based on how quickly they're moving forward with this. I would, at the very earliest, be early next year, I think.
Okay, thank you so much. Many parents and students may be wondering, what will happen if I don't comply? In other words, if they refuse to have their child vaccinated. Can you speak to that?
Yeah, it's hard to say. I mean, one thing I would like to point out is that this is no different than the other vaccines that kids are required to have in schools, or healthcare workers for that matter in hospitals. We've been required to have vaccines for MMR and for hepatitis, and all sorts of things are required to go to school. And this is no different than that. I feel like the community has reacted to it differently because of the COVID circumstances, and it's never happened in our lifetimes, right? But these things are things that are already required of our students. I imagine that if you refuse to get vaccinated, or if your children won't get vaccinated, or if you won't vaccinate your children, imagine you won't be able to go to school. that's probably what's going to happen.
Okay, I do have a follow-up comment or question later on having to do with exemptions, but I'll just leave that for the outline. For note for everyone, we received a number of questions. I did in particular from our community. So I've captured those and we may return to this particular detail. Thank you.
Okay, thank you. Obviously, COVID-19 is on everyone's mind and topic of conversation constantly. Do you have a sense of when the COVID-19 virus or pandemic will come to an end? And what, if anything, can be done to accelerate that ending?
Yeah, so this is I have a lot of opinions about this. So it's hard to have a crystal ball to see what's going to happen. So there's a number of factors at play here. So first of all, it's up to your own personal philosophy it's up to our own personal philosophies when the pandemic is over, right? So everyone has their own cutoff. How many deaths is too much in a month in our county? How much morbidity and mortality and hospitalization can we tolerate and say, okay, the pandemic is over? Because the first thing that I would say is that I don't think COVID is going anywhere. For the time being, it appears that it's here to stay. Even if we get 100% of our population fully vaccinated, it's unclear if that would eradicate COVID from our community. I don't know that it would. It may not be one of those viruses that's possible to eradicate. Like we've eradicated several viruses in human history, right? Through vaccination. We've eradicated smallpox. We've eradicated 2 out of the 3 versions of polio that cause paralysis, right? That cause people not to be able to walk or breathe. So there's a number of illnesses that we've been able to completely eradicate from the human population on Earth. But those viruses were less transmissible. They didn't mutate as fast. They were easy targets. Plus they were very debilitating diseases. And so, there's a huge push to get rid of those diseases and worldwide, and we did it. I don't know that COVID is really amenable to that. It may be too transmissible. It may not be infectious, and may not be deadly enough, right? So it's just one of those things that I think it's here to stay, and we're probably going to have to get booster vaccines every year, kind of like influenza, right? Influenza kills many people every year, and we have to get we should get influenza vaccines every year to protect ourselves from that. But we're not going to get rid of influenza anytime soon, right? So it's here to stay, I think. It's clear that we're not going to be able to convince everybody to get this life-saving vaccine because, there are differing opinions in our community, and people, it's never going to be a mandate for the community to get it. So it's here to stay. And when the pandemic is over is up to us to decide. I have personal criteria for when the pandemic is over for me, right? As a healthcare worker and a public health person. When we've achieved as many vaccinations as we can possibly get in the community, combined with when COVID is no longer overwhelming our hospitals and making it making it unable to provide quality care for the community, that's when the pandemic is over. So right now, for example, you look around the community, it looks okay. Everyone seems to be doing fine, right? We're wearing some masks, we're getting our vaccines. There's a big political debate that I'm trying not to pay attention to. But in the hospital, we have full ICU beds. And like just as of Tuesday this week, we had 8 people in this county in an ICU bed because of COVID. That means they're in trouble and they are likely to die. So that's 8 people in our county, and we only have normally 8 ICU beds in this county. The whole county only has 8 ICU beds, and every single one of them had a COVID patient in it. And you may say, well, that's what the hospital is there for. And this, but this isn't normal. Like normally those ICU beds are open and available for people with other diseases, like just a basic pneumonia that they could recover from, or maybe they had a a really serious case of appendicitis, and they got septic from it, and they needed to be in the ICU for a short while on antibiotics. We don't have any space for those poor people now because we have COVID patients in it, right? And so for me, the pandemic isn't over because we're still suffering at the hospital trying to figure out what to do with all these people. And while out in the community, it looks like everything's fine. In the hospital, it's chaos and it's really difficult. And we're watching people not get the care that they need because there are too many patients with COVID that could have been prevented if they just had a vaccine. So for me, the pandemic isn't over until that stops happening. After our hospitals can deal with the surge of COVID patients, unvaccinated COVID patients every season, then I'll consider the pandemic part of it to be over. And then it's just endemic. It's just part of our community.
Our ICU at Fairchild actually was 1 COVID patient yesterday and 3 non-COVID patients.
Awesome.
And our ICU South is closed as of now.
Perfect. So yeah, so that was earlier this week. So over the course of this week, those numbers have come down. So our current, Go ahead, Courtney.
Oh, I said I worked Monday as well, and our ICU was not full with COVID. We were full of, the beds were full, but they were not all COVID patients.
Right.
On Monday as well this week.
Yeah. So Courtney, I'm talking about countywide, right? So not just your hospital, but countywide. So that's just this week. So every week for the past 6 weeks before that, you know as well as I have that the numbers have been astronomical, right? So this is the first week where we've gotten a relief from that.
Thank you, Dr. Stutz, for really putting a personal twist and sharing your personal philosophy with us about that. I think it's really relevant to see your side of the issue. So thank you for that. Our communities have expressed quite vocal and vociferous opposition to the local school board, citing secondary and other effects that come with wearing masks all day long. Could we ask you to speak to that, or how do you respond to this concern?
So is the concern about like physical, effects of wearing a mask? Is that what we're concerned about?
There are some physical and there are also some trauma that we've heard about, some social emotional impacts as well.
Yeah, so I can speak to the physical stuff very easily. They don't affect your oxygenation levels. They don't even affect your dissolved blood CO2 levels. I've done this in the hospital, worn a mask all day and then put myself on an O2 monitor, or done an ABG on a patient who's had a mask on their entire visit. They don't affect your blood chemistry. Okay, it doesn't affect your ability to exchange gas, to absorb oxygen and breathe CO2 out. Surgeons wear them all day, every day in the hospital for more than 12 hours sometimes. So the idea that there's some sort of harmful physical thing from wearing a mask, I'm just not buying. I've worn masks for 36 hours straight. And, of course, I didn't get checked into a hospital to have any blood work done afterwards, but it's just not, it's not realistic. I don't know of any mechanism by which, if you had 20 masks piled on top of your face and it was difficult for you to breathe, okay, that might do something. So I'm just not buying that argument. It's not physically harmful to wear a simple mask around. It's a simple thing to ask people to do. Is it emotionally, psychologically stressful? COVID is psychologically stressful. Being in the hospital and intubated is psychologically stressful. The hospital workers are psychologically stressed out. I'm sure the community is too, from the impact to, our economy. So yeah, there are many parts of the pandemic that are psychologically stressful. Masks is probably the least part of that.
Thank you. We're going to check the chat. Ginger Lee, anything from your community?
I'm sorry, no, I don't have. I do see some Grenada community members there. If you guys want to send a message in the chat, then we can ask those questions. But at this time, I don't see one yet.
All right. If it's okay with you, I have a few
Yes, please.
I'll check back in with you gingerly. Thank you.
Okay.
A follow-up question or comment, Dr. Stutz, about the masks. Now, could you go a little bit more granular with respect to the paper and cloth? Some of our community members believe that paper and cloth in and of itself will not keep the virus out.
Yeah, actually, I'd love to talk about that because I've done some pretty extensive reading about how these masks work. And the bottom line is, it's not on a microscopic scale. Things don't work like a spaghetti colander, right? You can't, like spaghetti, you're filtering the water out of spaghetti in your sink, right? That's not how a mask works, right? It doesn't work by simply filtering out particles, okay? So by entrapping the larger particles, with holes that are smaller than those particles, right? That's not how it works. So the fabric masks have 3 layers. The first layer on the outside is made of usually polypropylene, and it's a water resistant layer that reflects moisture, right? The inner layer is a different polymer that absorbs moisture. It absorbs the moisture coming from your breath, right? And the very middle layer is a paper layer that electrostatically attracts particles that you breathe out of your mouth, including particles that contain virus, right? So even if you look up the size of a viral particle, right, it's like less than 0.2 microns. And you'll see that, okay, that particle is smaller than the size of the mask. So how could it possibly be blocking those viral particles from escaping? And the answer is they're electrostatically attracted to that middle layer of the mask. So they, because of chemistry and physics, right, they're electrostatically attracted to the mask. So they bind to the mask and they're electrostatically bound, kind of like static electricity, right? That's why the masks don't work all day. You kind of have to swap them out, those paper masks, once in a while, because they get overloaded with moisture and particles, right? So that's the answer to that question. They're more effective than a cloth mask too, because they're designed to trap your respiratory particles electrostatically.
All right, I'm going to do a time check. It's just about 9:30, and I actually have 5-6 more questions here from Scott Valley. So if it's okay, I'll begin, and then gingerly we'll check back in with you in just a bit. Okay, Dr. Stutz, when students and staff are vaccinated, assuming that we have 100 or close to 100%, will the mask mandate be lifted? One of our guests hopes so and thinks that not having to wear the mask would be a great incentive to being vaccinated.
I would hope so. Yeah. I mean, because our culture does not tolerate wearing masks. We're friendly people. We want to see people's faces and interact with one another. I hope that we can do away with a mask mandate in schools. The problem with that is that they are really effective. We are really effective at preventing transmission. And that is, hands down, the data has shown that on a population-wide basis. So, I'm hoping, yeah, if we can achieve, if we can achieve a state where we're not having outbreaks in schools and we don't have to wear masks, I think that's great.
Okay. Another guest asks, if COVID-19 vaccine works and is effective, how is it that unvaccinated individuals pose a threat to these vaccinated individuals?
Well, simply by transmitting the virus. I mean, it's so. The community that's against the vaccine really focused on this one article that was written that said that there was live vaccine discovered in the noses of vaccinated individuals. Well, that wasn't a surprise. I mean, nobody was in the scientific or medical community was surprised that you can still get infected and transmit COVID even if you're vaccinated, right? But what we also understand is that it's very likely, when the data, probably comes out by the end of this year, that if you're vaccinated, you're far less likely to transmit it to other people. So when you're unvaccinated, you're going to be more likely to transmit live virus to somebody else. So like every other transmissible disease on this planet, you're a risk to other people if you carry that virus around for longer periods of time. And if you're unvaccinated, you carry that virus around for longer periods of time, and you're more likely to be a threat to the rest of the community.
Okay. We also do, because I'm responsible for tracing, as you know, with the team here, and we have had individuals who were vaccinated, fully vaccinated, still test positive for COVID.
Yeah, that's absolutely true. So that goes along with what I just said, that vaccinated people are going to get COVID. Vaccinated people are going to die of COVID. It's a statistics game. It's, you know, how much impact can we have on that number? The more people we have vaccinated, the fewer people will die of COVID, but it's not going to be 100%, right?
Mhm.
One
well-
of our, sorry,
No, go ahead.
Anjali, go ahead. I can check in with you.
Okay. Just kind of following up on that, one of the questions kind of discusses a natural immunity and natural immunity compared to immunity derived from vaccine. And if there are long-term effects or side effects for the vaccine, who is going to pay those medical bills?
Yeah, so that's actually a wonderful question that opens up a whole new conversation that we could have, is what are the overall costs for a society of not getting vaccinated, or just COVID in general. So there have been so many economic impacts of this virus on our society, right? Not only the lockdowns from last year, the many dead people that could be participating in our community still if they hadn't died of COVID, right? People around for their families, able to work, right? What are health insurance companies going to do in the future? Are they going to cover your hospital stay if you're unvaccinated? Are they going to increase your insurance rates if you're not vaccinated because of your risk of dying of are they going to pass those costs on to the rest of the community? Are we going to have to pay for the fact that you're unvaccinated? And that means, and we have the same health insurance that you do. And are they going to pass those premiums on to the entire community? Our hospital is going to be able to make ends meet because of all the restrictions and because of COVID itself, and, you know, and staff members getting sick and that sort of a thing. You know, at least one of our community hospitals here is really financially suffering because of COVID. A number of them across the nation are, for many reasons. So yeah, what are the economic and financial impacts to our community because of COVID? There are many. Free shot is a really good way to prevent a lot of the, you know, morbidity and mortality that comes from severe COVID. And I think it's going to impact financially our community in positive ways as well. So yeah, is your hospital stay going to be covered? Well, probably for the time being. But what if we get to a point in the future where the evidence is so overwhelming that vaccination, you know, will prolong your life by allowing you to not die of COVID, or you know, just be impaired from your hospital stay from COVID? What if we get to a point where insurance companies will no longer decide to cover your hospital stay? We may get there. I don't know. Yeah, it's really hard to say.
Thank you.
Okay. Well, there are quite a number of active participants in Scott Valley. Let me get to one that seems, in my opinion, certainly out of my league, not something I ever had an opportunity to study. Dr. Stutz, this is regarding the Occupational Safety and Health Standards, OSHA, personal protective equipment. This caller or guest is stating that he has to follow 23 pages of respiratory protection, including training on approved face pieces, dust masks that must bear a NIOSH label for particle, bacteria, and moisture filtration efficiency, fit testing, change out logs of the maximum duration of continuous use, etc. Why don't these standards apply to school admin and student athletes who are in masks for 6+ hours a day?
Yeah, so it's difficult for me to answer that question for a number of reasons. First of all, it's Cal OSHA, and they make their own employer, you know, standards for employers, with which I have nothing to do. They make their decisions based on a panel of experts. That's different from the health experts in the state, right? Sorry, that's my kid. So I can't really tell you where, you know, how they come to those decisions. But of course, the schools are governed by one group of people in California, and employers are governed by another group of people in California, and their standards are different. It also depends on who the question came from. I don't know what line of work you work in. I don't know who you're employing, and I don't know what business you do. So it highly depends on what kind of business you're in. But yeah, different masking standards for different groups of people. That's okay. It's not the end of the world when there are different guidelines for different groups of people. It may not make sense, but the overarching objective here is to make people as safe as possible in a reasonable way. And some of those guidelines might not be reasonable. They're very difficult to follow. I would agree with you. And what may make sense for one business is not going to make sense for another business. Like for obviously in healthcare, when where you're much more likely to get exposed to COVID, and have different guidelines for those employees than we are if you're in the service industry, like if you work at a restaurant, right? So that's the way regulation works everywhere. Different guidelines for different groups of people.
Yes, I really appreciate that. I think it is frustrating. And we do, ladies and gentlemen and students, have quite a number of questions to still get through. And I know that there may be a feeling that there's a follow-up to this. I'd like to get through the initial questions, please, in light of the fact that it's at 9:36 right now. The next piece of this question has to do with the CDC asking or saying that information on the effectiveness of face masks and respirators for decreasing the risk of infection in community settings is extremely limited. Thus, it is difficult to assess their potential effectiveness in decreasing the risk of virus transmission in these settings. Have you or public health conducted a baseline study?
So we live in a super rural area, and we have a very small health department. We don't even have an epidemiologist on staff, like other larger counties do, who would be able to collate and process this data statistically. So even if we were able to carry out that kind of an analysis, that kind of a study, we wouldn't have anyone around to analyze the data. So there are entities and there are larger counties who are conducting this kind of research, and we're basing a lot of our decisions off of those studies. So I guess that would be the answer to that question. Is we're trying to keep up with vaccinating and getting the word out to the community about COVID information in general. And that's about all the staff that we have available for in public health in Siskiyou County. It's a huge job, even just doing that. And this is dozens and dozens of people that we have employed at this. So when COVID numbers go through the roof, we even have to call in state help to help us do the contact tracing and find out, who might have been exposed by that COVID positive case, right? So we have to call in state help just for that basic process. So it's pretty overwhelming, the current job as it is.
All right, I do want to acknowledge that there are two guests. I just sent a private message asking them to provide their question or comment in the chat. Their hands are raised. So I'm going to lower the hands and remind everybody to please do so. Thank you for cooperating with us. We have a lot to cover and not much time left. Ginger Lee, anything from the communities of Grenada?
Okay, so I had a flood of questions, and I know that there's not any way to get through all of the things that people are asking in the brief time we have left. But one of the things that does seem to be recurring is concern again about the long-term side effects of the vaccine and how you can move forward with vaccinating children without, years worth of studying those long-term effects.
Yeah, so that's really hard to describe to lay people who haven't been through medical school. How do we know that they're going to be? So we don't know 100% that they're going to be safe, but we do know when you go through medical school, you learn how the human body works. We learn how immunology works. It's not a giant mystery. A lot of this stuff we've kind of sorted out how a lot of this stuff works, and we can make reasonable estimations as to what's safe in the long term and what's not. If this were a new drug that you were going to be taking every day and we're a brand new class of drugs, that would be a different story. I would be very hesitant to recommend something like that to the population, even if it was effective for COVID. Like, for example, there's a new antiviral drug that's showing good effectiveness in COVID. If it were approved in children right now, I would not recommend that for kids, okay? Because drugs and vaccines are completely different things. And the problem with, in the public's mind, they're looking at the vaccine as a new drug or something like that, but it's not, because a drug is something that inhibits an enzyme in your body and you take every single day. And that's likely to cause long-term effects down the road that we don't know anything about, because we don't know what that enzyme really does in the body or whatever, right? That's a new drug. A vaccine interacts with the same immune system that we've been studying for decades now, in the same way that other vaccines do. It's just a different delivery mechanism. So we're pretty well able to predict the long-term effects of new vaccines because we know what they do to your body. We don't know what new drugs do to your body all the time. Okay, so from a physician's perspective, I can tell you that our general sense is that there aren't going to be any more long-term effects from these vaccines than there are from any other vaccine. And how can I say that? I can say that because I have decades of experience in medicine, and that's what I'm recommending. So are there the studies to back it up? No, we'd have to go years and years and years for those studies to back that up. And I'm pretty sure those studies will show long-term safety. This technology, though the delivery mechanism may be new, like the technology for vaccines is not new. The end result is the same. You get a small dose of something that resembles the virus, so it trains your immune system to react against it. The end result is the same. And so there isn't any good reason for there to be long-term downstream effects from that, because your body is exposed to new viruses all the time. So that's why physicians feel comfortable recommending this, especially in light of how disastrous COVID can be if you do get a natural infection with COVID. You know, if this were a vaccine for adenovirus or RSV or something that doesn't cause that much morbidity and mortality in our community, I wouldn't be recommending the vaccine for it either, right? So it's the combination of how dangerous COVID is and the likelihood with the very unlikely possibility that you're going to end up with long-term effects from the vaccine. Those two things together mean that we're going to recommend the vaccine. It's a heuristic sensitivity thing that physicians develop over time, knowing what is potentially dangerous and what is not for the human body. And it's very difficult to describe unless you are in medicine.
Thank you. We really appreciate that. Just so everybody knows, I'm going through the chats, I'm going through the list. There's a lot of activity. Thank you, everyone. We'll do our best. A question, if my child...
Also, I'm willing to stay on as long as you guys want and answer whatever questions you guys...
Oh, okay. Well, we don't want to take too much advantage of that, but we will check in at 10 to just, circle back to that. Thank you so much, Erin. A parent is asking, rightly so, a child who wears her mask consistently and correctly, maybe in classrooms with students who have exemptions or who are not in a mask. Therefore, we have a mask exemption. We have students that are largely in masks.
No masks at all. Yes, I get this question a lot, and I have a very easy answer for it. So it's not an all or none thing, right? If one person in the room is not wearing a mask, that doesn't make it ineffective for everybody else, right? So it's the more prevention we have, the less transmission we will see. It doesn't matter if only one person in that room is wearing a mask. That will help. It doesn't matter if 9 out of 10 or if all of them, right? The more mask wearing we have, the less transmission we will see, because it's over a large population of people, right? So yeah, if we were in a room full of 10 people and we were only studying those 10 people, okay, and one person was wearing a mask and the rest weren't, and they had COVID, that person's going to get COVID, right? Their mask isn't probably going to help them in that situation if we're only studying those 10 people. But if we're looking at the entire county and we have 20% of the county wearing a mask, and we have another county where 80% is wearing a mask, we will notice a difference in transmission, right? We will notice that in the statistics. It's easy to see. And so it's not an all or nothing thing. It's not, well, one person's not wearing a mask, so the rest of the community, it just doesn't even matter. Nobody should be wearing a mask. No, it's a continuum. It's not black and white. It's not on or off. It's a continuum. It's, oh, we got 1,000 cases instead of, 1,115 cases. We'll see the difference in transmission. It's a gradation. It's a continuum. It's not an all. So please do your part. It's a small part you are doing, but please do your part.
Gingerly checking in with you.
Okay, I'm just gonna kind of keep going in order that people have asked questions, unless I saw that some were very, very similar. So this person sent a similar question to that has already been asked, but if children are vaccinated, will it make a difference if parents are not, since kids will still be possibly carrying and transmitting, and yet, okay, possibly transmitting the vaccine, yet possibly asymptomatic. I think they mean COVID. So just a question regarding asymptomatic transmission and whether or not, schools and students being vaccinated compared to the community.
Right, yeah. So I think, again, it's a continuum, right? So if the parents aren't vaccinated, but the kids are, well, why even bother? Why should anybody? Well, it's a continuum. So that child will be less likely to pass it to their schoolmate, who will be less likely to pass it to their elderly grandmother, who will be less likely to die of COVID, right? And on a population-wide basis, if you do that enough times, you're going to save people's lives, right? And again, it's not an all or nothing. Just because the parents aren't vaccinated doesn't mean that the kids being vaccinated isn't going to do anything. It probably will on a population-wide basis. I guess that's what that question was aimed at.
Anything else, Gingerly?
Just looking down just a second. Okay, one person has asked several kind of long questions, so I'm just going to read through a couple of them. Statistics are showing that there has been transmission from both vaccinated and unvaccinated. There are medical issues such as clotting and myocarditis. In children from the vaccine, the risk of serious illness or death is low from COVID. The outbreaks are already down in schools, then why force this now? As a parent, the risk does not outweigh the benefit. Also, same person, in hospitals, we're seeing more vaccinated patients than repeat COVID positive patients. Why is natural immunity not being accepted? I'm assuming when it comes to the vaccine, to the mandate. And lastly, we see, again, the clotting, arterial fibrillation, myocarditis, and that's just a few. This is also just at our small local hospitals.
Yeah.
There is a risk that it is not being taken responsible for. When will all of this be acknowledged?
Yeah, so all of these things are already acknowledged, and I'm going to acknowledge them right now. Great question. Valid concerns. In the public's mind, they hear about these cases, which they're real cases of myocarditis, real cases of blood clots, probably caused by the vaccine nationwide. These are studied and gathered together in a data set very closely. I've seen maybe one or maybe two cases of vaccine-related blood clots over the last year. In my own practice at the hospital as an emergency physician, I have seen this with my own eyes, okay? And I'm still recommending the vaccine. So why am I recommending the vaccine when, I've seen it cause blood clots and, possibly one case of myositis in a patient? Well, the answer is that the data shows that those things are a 1 in a million chance. And I'm not just exaggerating by saying 1 in a million, I'm saying exactly 1 in a million, because the data shows that out of 1 million people that receive a vaccine, one of those people might have a blood clot or a case of myositis or cardiomyopathy. 1 in a million. It's almost exact 6 million in six patients in 6.8 million vaccinated people. Was the number of patients that had central venous sinus thrombosis. You all remember last year when Johnson & Johnson vaccine got put on hold because there was a concern about central venous sinus thrombosis in patients who had received the J&J vaccine. That was a real thing. The vaccine actually caused that to happen, at least in our opinion. But it's a 1 in a million chance, right? And for the record, most of those people got better and did fine. One of those people died of the central venous sinus thrombosis, right? So, but when you get COVID, at the very least, you have a 2 in 100 chance of dying, right? You have a 2% chance of dying of COVID. So all you're doing in medicine is you're exchanging one risk for another. That's why we're still recommending the vaccine, because you're exchanging because I can say with pretty good certainty that if you're not vaccinated, you're very likely to get COVID during your lifetime at this point, very likely. All of us have had the flu at one point in our lives, and all of us are likely to get COVID at one point in our lives or get exposed to it. If you're unvaccinated, you have a 2% chance of dying of COVID.
What about pediatric deaths?
Hold on a second, Courtney. Thank you very much. If you get the vaccine, you have you're exchanging that risk for a 1 in a million chance of maybe getting a blood clot that might kill you, right? So that's the only reason that we're still recommending it. So Courtney, go ahead. What about pediatrics?
Well, I think this conference call was meant to be geared towards school age children, and I don't think that's the correct death rate in school age children. And
you're right.
and if you would speak to the VAERS data for pediatric deaths that have been associated with the COVID vaccine, I have quite a few listed if you haven't read them.
I would. So here's the thing about the VAERS database, right? So it's open for anyone to make a report, right? A member from the community can make a report saying that they had a reaction from the vaccine. A member of the healthcare community can make a report if they believe that there has been a reaction secondary to the vaccine, right? Anyone can make a report into the VAERS system. They're not verified. They're not checked in any way. And so let me give you an example. So of the 2 patients that I've had come through my emergency department with what I believe were vaccine-related events, right? Maybe like a myositis was one of them, and a blood clot that I thought might be related to the vaccine because they had been recently vaccinated. It was still impossible for me to tell if that was the actual cause of what was happening to that patient, right? So when a 28-year-old female comes into my emergency department and they have a blood clot in their lung and they say, I think this was because of the vaccine. I just got it 3 weeks ago. Yeah, that's very possible. But there's no test that I can do to prove that. And anyway, I see 28-year-old females come into my emergency department with blood clots all the time. Anyway, even before COVID. So how can I possibly tell if that was related to COVID or not? There's no test that I can do. Even if that person was a wonderfully healthy person before that. I see wonderfully healthy people get blood clots all the time. I see wonderfully healthy people get myositis and cardiomyopathy all the time, even without COVID, even before the COVID vaccine. So how do I go into the VAERS system and log in and say, I think that was related to the vaccine? I can do it, but what's my cutoff? Is it, what are the criteria for deciding what is secondary to the vaccine and what isn't? That's what you're looking at when you look at the VAERS system. You're seeing all these reports, but that's all they are, is just reports. Nobody has gone through to scientifically prove that these people had this reaction because of the vaccine. Some of them certainly are from the vaccine. They certainly are side effects from the vaccine. I'm sure people have certainly died because of the vaccine, but it's very difficult to sort out the chaff in that VAERS report from the real things. And so as an example, when we decided that we thought those central venous sinus thrombosis cases were from the J&J vaccine, that was somebody going through the data and saying, look, this is a really rare thing. central venous sinus thrombosis is extremely rare. And we have 6 young women, they were all women, who have had the vaccine and within 3 weeks had a central venous sinus thrombosis diagnosis. That is really rare. That is from the vaccine, and that deserves research and concern, right? But all these other things that we can't separate from what's normal and what's not, it's very difficult to say, right? So yeah, I'm sure there are many, many case reports of kids dying in the VAERS system after getting their vaccine. But how do we tell if they're real or not? We have to wait for the statistics to kick in to tell us how likely or unlikely this was, right? We can't just look at the VAERS system and say, oh, there's reports of kids dying, so there, right? And so, yeah, is it more dangerous for kids to get the vaccine because they're less likely to have side effects from COVID? Maybe, that's what I'm waiting for. That's why I'm waiting for the data.
Well, we don't have long-term data on that. We won't have it before we have to make a choice to vaccinate our children.
We don't have it, but it's going to be required for schools. We live in a society where there are rules, and you gotta stop at a stop sign, right? You can't shoot your gun off in any direction in the community because it's not right?
So I just want to ask a question in regards to you saying reporting things to VAERS and not really being certain about what is and what isn't, but in regards to like COVID-19 deaths and stuff like that, like how can you report a death if someone has like something else going on, but then they die and they tested positive for COVID, but then they can be written down for a COVID death? So that's kind of confusing to me, because it's like, you don't know that person died of COVID, just like you don't know that 28-year-old that came with a blood clot, if it's from the vaccine or not. So not reporting that to VAERS because of that seems kind of.
No, I wasn't suggesting that you not report it to VAERS. I'm just saying that when you look at the VAERS data, how do you report it to VAERS if you think that it's even remotely related to the vaccine, right? So yeah, how do we decide if somebody actually died of COVID? Well, that is a wonderful question that I would like to address, because a lot of my job is trying to figure out, did COVID or not, and should we count it as a COVID death, because we want the numbers to be accurate, right? So if somebody dies in the community and they just had a positive COVID test recently, that's almost that we're talking about. That's not good enough for me, right? I don't want to call it a COVID death just because somebody was found dead at home and they had a COVID positive test like a month ago, right? I've had a number of those cases come across my desk, and I'm not interested unless there was something else that demonstrated that it was related to COVID. For example, maybe they went into the hospital the day before that and had a chest x-ray. And we go back and we look at the chest x-ray and we say, oh my God, they had a COVID positive test. They had a chest x-ray now that looks like COVID, because COVID looks very distinct on a chest x-ray, I will tell you. Having seen it enough to call it a COVID death, because we have not only just the positive COVID test, but corroborating information that they had COVID. We had a chest x-ray that looked like COVID and they died, right? So there has to be something else. It can't just be, oh, they had a positive COVID test. Or, it can't just be, oh, well, the person was sick at home and the family members say that everybody was sick with a febrile illness and they were coughing, and then that person died, and one of the people in the household tested positive for COVID. Well, in some communities, that has been enough to call a COVID test. That person died of a respiratory illness at home. They had a known febrile illness, and one of the members in their family turned up positive for COVID. Personally, for me, that's not enough, right? And so a lot of my job is I get presented with these cases, should we call it a COVID death or not? And it's not clear at all. And a lot of the times the evidence just isn't good enough for me, and I don't want to call it a COVID death. So you're right. There are a lot of factors that play into deciding if this person had a bad outcome from COVID or not. How close it was from their positive test. Did they have classic symptoms? Did they have any laboratory evidence or chest x-ray evidence or CT evidence of COVID? that sort of a thing. Did they get exposed to a known COVID positive case? All those factors go into play, and then you make a judgment call. Yeah, there's 2 factors that lean towards COVID, and there's 10 other factors that don't. I'm going to not call this a COVID death right now. Or in this other case, it's overwhelmingly clear that they died of COVID, right? So yes, these things are judgment calls based on our intuition. And intuition is something that healthcare workers develop after they've been working in healthcare for a long time. So that's how we make those decisions. They're very difficult decisions to make, you're right, and they're not always accurate. There are probably many people who we classified as COVID deaths in nationwide who weren't COVID deaths. They had a lot of other factors at play. And there are many people who died in the community who didn't get called COVID deaths, who probably were COVID deaths. We're just trying to be as accurate as possible. And we know that we are not going to be 100% accurate, right?
Thank you so much. It is 10 o'clock or just 1 minute after. And thank you, Dr. Stutz, for offering to stay on. What I'd like to suggest that we do is honor the questions that were posed in the chat or in an email communication earlier due to the time factor. And then perhaps when we get to the end, we'll ask, I see a hand raised, and if you could just please hang on so that we can get through all the material and honor everyone's time. I'd like to continue. There is a follow-up question to Ginger Lee's question earlier, Dr. Stutz, that you spoke to. So if you don't mind addressing a previous question. Both the Oxford study and a recent US study are showing that the viral load for the vaccinated and unvaccinated is equal. You spoke, glad you're recognizing this and it's making sense to you here. Previously, you spoke as to that being the reason for the unvaccinated being a danger to the vaccinated as far as transmission. There is also a recent study showing that Pfizer loses efficacy after 60 days. Though that not necessarily hospitalizations. Are you aware of these more recent studies, and how does that affect the concept of the unvaccinated person being more of a threat as far as transmission? And if boosters are only yearly, how does that fix the gap?
That's a great question. Those are all wonderful questions. And the person is absolutely right. Those studies exist. The only thing is that, like, when the public sees a study like this, they tend to like grab onto like the most obvious answer. And so like, for example, viral loads, right? A viral load is, they're calculating how many viral particles or how much viral RNA was in your nose at the time that they did the swab, right? So they're trying to quantify that with a number, right? And a lot of the times they're quantifying that using the amount of RNA that they found in that person's nasal passage when they did the swab. Sometimes they're doing more sophisticated studies where they actually count the number of viral particles by collecting them and then diluting them out onto agar plates and stuff. And but the thing is that doesn't translate to transmissibility, right? Necessarily. That's just one number. Like the viral load present in somebody's nose at 5 o'clock in the morning or whenever they did the test, right? How does that translate to how transmissible that virus is to other people? Because those studies didn't do anything to quantify how transmissible that virus that they found was, right? They didn't do any population-based studies to say, okay, we followed these people around who were vaccinated who had known viral loads, and we demonstrated that they transmitted it to other people just as easily as people who were not vaccinated, right? So we don't know, even though the virus is there in a vaccinated person's nose and an unvaccinated person's nose, we don't know how the difference in transmissibility between those viral particles, right? So maybe the virus in the nose of a vaccinated person is covered with antibodies and not capable of really transmitting or replicating inside of human cells. Maybe it's less transmissible, right? We don't have the studies to support that yet. We don't know. Maybe it's just as transmissible. Maybe it's transmissible at the time that they did the swab in their nose, but maybe it's only transmissible for 2 days instead of the 7 days that it's transmissible in a person who's unvaccinated, right? So we haven't, there are more studies that need to be done. It's not just as simple as counting the amount of virus that's in somebody's nose. We have to quantify, is that actually being transmitted to other people, right? We don't have, those studies take a long time to do accurately. And it's very difficult to conduct those kinds of studies. They're called outcomes-based studies. It's evidence-based medicine, and they're outcomes-based studies, meaning what was the final outcome? Did it cause disease in other people or not? Did it cause death and disease? Did vaccination prevent death and disease? We're going to have more studies to answer those questions. But I think, and this is just my medical intuition speaking again, just knowing what I know over the last 2 decades of being in medicine, I'm fairly certain that the data will show that people who are vaccinated are transmitting it to people less frequently. I'm pretty sure that that's what it's going to show. I'd be surprised, and it's possible that that's not the case, but I'm pretty sure that that's what the data is going to show, and some of it already is starting to show that. If you know, given we know that the Pfizer vaccine and some of the other vaccine preparations lose efficacy, you know, over 3 to 6 months, yeah, that's a problem if we're only going to get a booster every year, right? But again, it's not black or white. It's not on or off. It's a continuum. So if I could convince everybody to get a COVID vaccine once a year, that to me would be enough. That would be plenty.
Thank you. I'd like to shift over to one of our students, please. We have student voice in the room, everyone, as a reminder for those of you who joined after we got started. One of our students, oh my goodness, and the questions keep coming. This is really terrific. Thank you, everyone. A student of ours from our high school wants to know why they give us the vaccine if people are still getting COVID-19 with the vaccine.
Yeah, so that's a great question. You know that's going to happen, right? So we know that vaccines aren't 100% effective. We know that that even with other vaccines, you know, like influenza or measles, mumps, and rubella, right? None of them are 100% effective. In order for a vaccine to even work and to protect you from an infection, you actually have to get infected with the virus first, right? So it's hard to picture in your head, but when you're giving someone a vaccine, you're training their immune system. It's like their immune system is going to the gym and lifting weights and getting ready for the invasion, right? And then when the invasion happens, they're able to handle it a lot better, right? So your immune system, even though you're getting infected with the virus, your immune system is doing a better job at fighting it off. You're still going to get COVID, even if you have a vaccine. It's just that your experience is going to be a lot gentler and you're going to be a lot less likely to transmit it to somebody else. So.
Thank you. I'm going to move on to some of the questions that are going to take it back down, if you will, for just a moment, to classrooms and to kids and teachers. Lots of information here. This is your profession, Dr. Stutz. We're so grateful. You know, for me, I'm just going to say, I've been in education for 30 some years, and still there's so much for me to learn. But hearing you talk about this certainly makes me think about how our lives are different now, that there's so much information at the accessible to our fingertips, if you will. And life just seems to be moving so much more swiftly, you know, than back in, you know, my youth, at least, that it just complicates everything even more. So thank you for bearing with us and for being patient and for really sophisticating and honoring our questions. Specific to classrooms and schools, with assuming that the legislation and all the other steps will take place, and now we're at the point where vaccines are required at that point in time, do you believe, or will there be a way to prevent fraudulent claims for religious, personal, and medical exemptions?
Yeah, that's a huge area of concern. It's going to be very difficult, I think. One thing is that because it's a state health officer order right now, there are religious and medical exemptions. There will always be medical exemptions, and it will always be difficult to prevent rogue medical providers from providing falsified exemptions. That's always been a problem in medicine, even before COVID. But as far as religious exemption, it's hard to say what's a fraudulent religious exemption, right? I mean, if it's the standard is that if it's an honestly held spiritual belief, that's the standard. that is a judgment call on the part of whoever is examining that exemption. It has no hard and fast criteria. I would say though that because it's a state health officer order, the religious exemption has to be there. If it gets regulated by the actual state legislature, that religious exemption may go away. If it gets mandated legislatively in the state or in any state, they don't have to abide by religious exemption in the law. So that exemption possibility may disappear if it actually gets legislated and not just from being a state health officer order. So the answer is it'll be difficult to prevent for the time being.
Okay, I have a question with respect to a treatment drug, perhaps. What is the effectiveness of ivermectin? We've heard that it's being used in the community. Can you speak to ivermectin?
Yeah, that's also a great question. I think that there is some good data supporting the use of ivermectin with in cases of COVID and in prevention. However, most of the studies that are being touted as supporting ivermectin aren't really up to the standards of what most US-based physicians are used to reading. They aren't used to reading data that comes from studies that are that poorly designed. The studies that support it aren't really designed up to the standards that we're used to. So there are several clinical trials going on.
Because I have lots of outside. Yeah. They're like, at Heather's house.
There are several clinical trials going on in the United States right now that are up to these standards, that were designed in a way that where we can trust them, randomized controlled trials, right? In a way that US-based physicians are used to interacting with and reading. So if you go to the clinical trials, trials.gov, you can find several of these studies that are currently hopefully going to answer this question. I'm hoping by the end of the year, but I'm thinking probably maybe early next year at this point. They'll tell us whether ivermectin is effective for prevention and treatment of COVID. However, in the meantime, physicians may do whatever they want. If they feel that the data is good enough for them, they may prescribe it to their patients, and you can probably find physicians who will do that. Most physicians right now are pretty skeptical. We would have, I feel like, this is my personal feeling, I feel like we would have seen more benefit from ivermectin at this point if it were as effective as it's touted to be. One thing that's not in dispute is the efficacy of the vaccine in keeping you out of the hospital and keeping you from dying of COVID. So if you really want to do something for yourself, don't take ivermectin, do the other thing that has all the good data behind it, the vaccine, right? Ivermectin might be helpful, it certainly might, but my gut feeling is that it's not going to be shown to be as effective as just the vaccine and you know, some of these other therapies like dexamethasone, steroids, right? In people who are hypoxic with COVID. We know those things are effective because the data clearly shows it. Data's just not so clear with ivermectin right now. So.
Okay, another question from one of our students, and this happens since we play in our athletic competitions. The officer from Modoc County is enforcing optional masks. Why are we enforcing required masks?
Is that for sports, they said?
Sports, yes, and just perhaps generally speaking.
Yeah, so for schools, masks are required by CDPH. This isn't an option. That it's not up to that health officer to free his educational departments from those requirements. It's not up to me. I could tell the schools in our county that masking is suddenly optional, but it's not my decision to make. That has come from CDPH. Kids and staff members in schools are required to wear masks in schools, and I have no say in it. I can't allow schools to not abide by those rules. It's a state level order, and that's that.
Okay, Ginger Lee, anything from Grenada?
I mean, I kind of feel like some of these questions have been asked, but sometimes in the re-asking, there's different like nuances. The most recent question was asking specifically about the vaccine and the mandate when the study itself says it won't be completed until May 31st, 2023. The protocol submission was October 7, 2020. How can you trust the effectiveness and the data and the safety when the study isn't actually complete yet? And I honestly, the study is not linked, so I'm not sure exactly.
Yeah, hard to say. I guess I'd have to look at it. I mean,
Mhm.
even though, so the study data was submitted, right? So we're free to look at that data and make a determination for ourselves. So like physicians are fairly skilled at, statistical, data interpretation in terms of safety and efficacy. That's the whole point in going to medical school, is not just to learn how to do an appendectomy and, like prescribe medications and dosages and things like that, procedural things. It's modern medical education is focused on learning how to statistically interpret data to decide what is safe and what is the best course of therapy for a patient for you to recommend, right? That involves a lot of high-level statistics and data interpretation, deciding what is a good study and what is not a good study. So whether or not an accrediting body or the FDA, approves for safety and efficacy of particular therapy, physicians themselves are still endowed with enough education to kind of interpret these studies on their own, right? Plus, they also have, many years of experience in healthcare, gaining a heuristic understanding of how, and by that I mean like just an innate sense of what's dangerous and what's not in healthcare, right? That they're able to advise patients based on gut feelings, right? Your sensitivity. When somebody comes into the emergency department and they have an abdominal pain or whatever it is, it's not a giant mystery to most physicians what the possible causes of abdominal pain could be. They've seen it so many times, right, that they have a list of things already prepared in their mind. And then when they go see the patient, they get more of a sense. It's the art of medicine, right? They get more of a sense of what could be wrong with that patient. They're able to narrow down what's wrong, not just based on laboratory data and imaging and sciencey stuff. It's based on a gut feeling, right? A sensitivity, the artistic part of medicine, the sensitivity you have because you have a lot of experience dealing with these situations before, right? So that's what I'm trying to communicate here, is that the gut feeling of most physicians, and I will tell you 90+% of physicians are vaccinated nationwide, and there's a good reason for that. There's a very good reason for that, because physicians have a gut feeling that these vaccines are safe and effective. And that's the best answer I can offer to that question, is that physicians and healthcare practitioners in general develop a very good sensitivity for what's safe.
The person did link the study, so certainly not enough time in this format to go through the whole study, but I will share that link with you.
Okay, thank you, Gingerly. Dr. Stutz, there are some questions that have to do with the requirement to order or require vaccines versus prior or other laws or codes. So this question has to do with, can you assure the people of Siskiyou County that mandatory vaccination is not a violation of the Nuremberg Code or other previous rules having to do with medical freedom, et cetera?
Yeah, no, I cannot, because I'm not a legal expert. I'm only a medical expert. I know a lot of medical legal concepts, and I'm pretty good with medical legal stuff, but I don't know enough to know whether this is, a violation of anybody's, basic rights or, that are codified in our Constitution or anything like that. I can tell you that that the only evidence that we have in the Supreme Court for supporting mandatory vaccination comes from the early 1900s, when there were smallpox outbreaks in the United States. And at that time, the Supreme Court did uphold the concept of mandatory public vaccinations for public safety. That's the only evident, medical legal evidence I can provide you to say that, well, historically, vaccine mandates have been supported for the good of the community. Whether or not you feel it's a violation of your personal freedoms is up to every individual to decide. But as far as the legal part of it, that's going to have to be hashed out in the courts, and I don't really have a good answer to that.
Okay, Ginger Lee, anything from Grenada?
Sorry, there are so many questions. It is definitely hard to scroll through everything. There is someone who has asked, obviously seen, certain videos or things on social media, I assume, regarding vaccines and becoming magnetic. I'm trying to find the question again while I'm scrolling.
And I think there's possible, Ginger Lee, that some of the participants or guests might be from one or our other communities, but might be asking the question to both of us. So I just want to check in a little bit with some of our guests. Forgive me for mispronouncing this this nickname or this name. I don't know if it's pronounced one way or the other. So this is MEXINAS. Would you please make yourself known?
Yes.
Great. Hi there.
Hello.
Did you have a question?
Yes, I already sent it to the chat. You're supposed to get it.
I don't, is it Mejinas?
Yes.
I do not have the question. I'm so sorry. I've been looking for your questions.
Okay, I get it right here. This question is for him. Can you please advise the approved legal status of the vaccine and if it is experimental? Yes or not? Simple question.
Yeah. So some of the vaccines are fully approved, right, in certain age groups. So, right, the Pfizer and the Moderna, right, and the Johnson & Johnson are approved, fully approved for adults, right? Some of those are emergency use authorized, approved, right, for certain age groups, meaning they're not fully approved. The word experimental, I would need a definition of that. That's the problem, is like, what's your definition of experimental?
My definition for experimental for us, when I used to be in chemistry, we use rat labs. So we do experiments with the rats. So right now we are not rats. So English is my second language. I don't have any degree, so don't expect me to talk to you so professional. So pretty much we are being the government rat labs.
Yeah, okay, that makes sense. Yeah, that makes sense.
You know what I'm saying?
So yeah, so are we lab rats? Well, the answer to that is that they already did those parts of the studies on the vaccine. They already used lab rats to study.
In 6 months?
Yeah. Yeah.
But they have many years with cancer and they haven't found a cure for cancer?
What's the question?
They have this many years with cancer and they haven't cured for cancer?
Yeah.
They found it in 6 months.
Yeah, that comes from the difference between cancer and a virus. I mean, cancer is a lot. There are thousands of types of cancer, right? We've actually cured some types of cancer, like leukemia, right? So you can't really compare one virus and thousands of types of cancer. It's apples and oranges. It's
okay.
Yeah.
Fair. I'm representing around 200 parents. I'm representing around 200. Oh, sorry. Around 200 parents. So I'm just going to go to the next question. Can you please provide details and assurance that the vaccine has been fully independently and rigorously tested against control groups and the subsequent outcome of those tests?
So again, for some age groups, it has been fully and rigorously tested, right? For the groups that it has been approved for, right? It hasn't met the criteria yet for kids under the age of 12, right? So that's currently what the studies are meant to address. And so that data isn't there yet.
Okay, what about the ingredients? Can you fully advise of the vaccine ingredient, the content of the vaccine, if they are toxic to the body? That was another parent there. Send me the question to ask you.
Yeah, totally. Yeah. So there are 4 components to these new mRNA vaccines. I can't really speak to the Johnson & Johnson. There are 4 ingredients in the mRNA vaccines, right? The first one is the mRNA, right? The actual mRNA encoding, carrying the code of what we're trying to fight against, right? There is a lipid, which is like a fatty substance that coats the outside surface of the mRNA and allows your cells to absorb it, right? So it can react against it. There is saline, meaning there's like sodium chloride, it's salt, right? Then there's a buffer. There's an acidic basic buffer solution, kind of like how, like in a can of soda, right? They moderate the pH, the acidity levels of the can of soda using sometimes phosphoric acid, right? Or phosphate buffer. So that's it. There's salt, there's a buffer, a pH buffer, there's a lipid or a fat, right? And there's the mRNA. There's 4 ingredients to those things.
Okay, so if it only has those 4 ingredients, can you explain, this is my question, why some of my relatives got the shot, why the magnets are sticking to their arms after they got the shot? It doesn't have iron, it doesn't have nickel, it doesn't have titanium, it doesn't have carbon, it doesn't have aluminum, does it have bismuth? So why the magnet is stuck into their arm if it's only 4 ingredients? Because a magnetic field attracts to another metal. So are you misinformed or what's going on? Because the magnets are sticking
Yeah,
to...
I can tell you right there that's probably not what's happening. I mean, that's everything I know about chemistry and physics is unfortunately a lot of stuff that I've had to go through to get to where I am right now. That's not possible, okay? It's just not possible and it doesn't make any sense. So
Okay. I might get, if you can send me your email and I might be able to send you a video because YouTube is taking him down because it doesn't stick to me, but it stick to them. I mean, they're Caucasian, 2 of them are Caucasians. I'm Mexican, so maybe the magnet doesn't like my skin color, but it doesn't stick to me. Next question from a different parent. So the mRNA gene is not an alternating therapy then?
is not a what?
Altering therapy.
Alternative therapy, I think.
Oh, there you go. Something like that.
Yeah, well, I mean, I don't know. It depends again on what your definition of alternative therapy is, right? I mean, it's an effective therapy. I'll tell you that. It makes sense mechanistically and scientifically how it works. It's very easy to understand if you know kind of how mRNA works in the human body in general. So I don't know how to answer the question.
Okay, can you please advise the likely risk of fatality to our children? Because I'm talking for around 200 parents, our children to contact COVID and the likelihood of recovery?
Of COVID or the vaccine?
Of COVID, because people with the vaccine still getting COVID. But with the vaccine, well, now we have a new variant because our antibodies are fighting your guys' antibodies, and then we got a mutant antibody now. Is the variant Delta?
Okay, well, I can tell you like the risk of COVID, it's like itself to like for adults, right? It's about 2%, right? It's about 2% of COVID. We have maybe a 1 in 1,000 chance if you're a kid of dying of COVID, right? It's pretty
okay.
I don't think that's true.
1 of 1,000. So that means you guys already tried more than 1,000 kids and one of them died, because I don't want mine to be the 1 of 1,000, so I'd rather pass.
Wait, the vaccine? So sorry, I'm just not understanding.
We're talking about the kids. We're talking about the kids. 1 of 1,000 of the kids is going to die of when they get the vaccine.
No, then not the vaccine. Yeah, I mean, I haven't seen the data on the vaccine in young kids yet, so I can't really tell you what the risk of the vaccine is for young kids yet.
You should talk to a local hospital. They are hiding some of those things right here. They haven't died, but they're really sick. Okay, next question. Can you please advise if our child were to experience any reactions to them? Can you please advise if any of the children were to experience any reactions if the manufacturer of the vaccine is liable? Question mark. If the manufacturer isn't liable, will the school district that my child is be responsible and liable as it is their request? Our children have the vaccine in order to carry on and attend school. Who's going to be responsible when there's something wrong? It's going to be the manufacturer, or we go after the school district or the school?
Well, I don't know. I'm sorry. That sounds like a legal question that I don't have the answer to. I mean, you mean if somebody's injured from the vaccine, who's going to be held responsible? I mean,
yes.
So
we go after the school district or after you guys or the manufacturer, whatever.
I don't know. I mean, that was up to the courts to decide who's responsible for those kinds of things. Yeah,
one of the parents says once we have received the information that we have asked in full, and we are satisfied with there is not a threat to the children's health, we be happy to accept or offer to receive the treatment, but with certain conditions. Mainly that number 1, you or your company confirm in writing that the child will not suffer harm. Number 2, follow acceptance of these. The offer must be signed in a fully qualified doctor who will take full legal and financial responsibility for the injuries occurred to the children and or any interactions by authorized personnel regarding these procedures. In the event that the children are declined to offer the vaccination, please confirm that children and parents will not be compromised and will not suffer prejudice and discriminations as a result.
Thank you, Mr. Mejidas. We're going to take this last question comment, please, so we can move on to be fair. And feel free to contact any one of us for some follow-up. Dr. Stutz, would you like to respond to that, please?
Yeah, so I guess I would respond to the part that I understood, which was that, yeah, physicians are already financially, legally, morally responsible for every treatment that they recommend to their patients. That's why the malpractice system exists, and that's why the medical board exists. They're already completely responsible for every medical decision that they're making, on behalf of patients and for patients, and all of their recommendations are scrutinized. So physicians are sued and held to high standards all the time. That's not any different here in this case.
Okay, great. We also have some other hands that have been up waiting patiently. I'll check in with Eric Gray and then Courtney Hansen.
Hey, can you hear me?
Yes.
Awesome. Thanks for taking my question. So I had a question real quick about when you said that 1 in 1,000 kids have died. So what's the solid number on that in the United States? Do you know?
I don't contend that 1 in 1,000 kids who've gotten COVID have died, but I'm putting it less than 1 in 1,000 of dying if you're a kid and you have COVID.
Sorry, maybe I misunderstood you, but do you have a number for that? I don't know. I can't seem to find a solid number anywhere. And you said VAERS, it seems kind of unreliable.
Wait, you mean the vaccine or COVID?
Just COVID.
Oh, just COVID. I mean, yeah, that's going to be on a state by state basis. I could go look up those numbers for you. It's very low. numbers of kids who've died of COVID is very low. You know, a good comparison would be like the number of kids who die yearly of influenza, right? So in an average year, we get about 30 to 60,000 deaths from influenza, right? In adults, and in kids, we get somewhere between 100 to 600 deaths in influenza, right, every year. Last year was amazing because we didn't really have very much influenza at all. So we only had like one pediatric death from influenza last year. So you can see, at least for influenza, the risk of dying as a child is quite low. It's probably about 100 times lower than it is for an adult. So I would expect it to be about the same for COVID. The numbers have been so low for our county for pediatric, you know, for serious pediatric cases. It's really difficult for me to get a sense of what kids' risks is for COVID. But you know, I'm sure we'll know more when all the data starts to roll in, you know, especially after a year of vaccination. We'll be able to see how we'll actually calculate how much pediatric morbidity and mortality is being prevented by being vaccinated, and we'll have better answers to that question.
Okay, thank you. Gingerly, anything before we move on to Courtney? She's had her hand up as well, waiting patiently.
Okay, well, it actually, one of the questions kind of follows up with that. So if you haven't seen the data for the research in young children, from the research and the studies, why should we vaccinate our children, especially when they have shown to have a natural immunity to COVID?
Yeah, you know, I would have to, you know, have to see the data in order to recommend that you get your kid vaccinated. I have not seen the data for kids under 12 years of age. If I see the data and it shows that, you know, there's more harm than good, then I wouldn't recommend it, right? So I'm not recommending that everyone run out and vaccinate their children yet. I'm just saying that in the event, it appears that the state is going to require it in the event that that data does come in and demonstrates that it's safe and effective. That is their plan right now. I'm not recommending it to anyone's kids at the moment, and not until I see the data, you know.
Thank you for clarifying that, Dr. Stutz.
Okay, Courtney, are you still there?
I am, yeah, thank you.
Thanks.
I have the total number of deaths for the United States since COVID came to our shores is 3,062 that they're attributing. That was as of Monday to pediatric patients. That's the number that I found on a government website. I could attach it if you guys want.
That's great. So if we can compare.
And I have a question as well.
Yeah, if we can, let's just briefly compare that to influenza right now. So in an average influenza year, we get.
But that's since last year. That wasn't just this year. That's last year as well when it began. So that's almost a 2-year total.
Let's do 2 years. So let's divide it in half and do 1,500. So we had roughly 1,500 deaths over, you know, per year. And in an average influenza year, we would get somewhere between 200 and 600 pediatric deaths nationwide from influenza. So you can compare that to influenza and see, you know, how, and make a choice for yourself how dangerous you think COVID is for kids.
Okay. Would you mind speaking to the natural immunity versus vaccine induced immunity in COVID and the research behind it, and if we will be accepting natural immunity in our kids at school?
Yeah, that's a great question. Natural immunity is the most powerful form of immunity. I would definitely agree with, you know, obviously the point of your question there. People who have had a natural COVID infection are far less likely to get a future infection over the next 6 months. Better than if all you've had is a vaccine, for sure. However, the best protection for reinfection is having had COVID, right? Having had COVID and having a vaccine on top of having had COVID. So the data shows that the strongest, the people who are the least likely to get infected by COVID are people who've had COVID and had a vaccine. Next below that is if you just had COVID and you haven't had a vaccine, and then below that is if you've had a vaccine but haven't had actual COVID. And then below that is, of course, is unvaccinated, right? Those are the people that are, from least likely to most likely to contract new COVID and have a bad outcome, COVID diagnosis, right? So yeah, having had COVID confers a really, really strong natural immunity.
Why is that not being recognized as, I'm not sure why that's not being recognized, especially since most of our kiddos are, my 3 children had COVID and they had very incredibly mild symptoms. Some are asymptomatic. We could have lots of kids that have natural immunity already that do not require vaccination.
Yeah, I agree. And that's been brought up by the health officers to CDPH several times. Why are we not acknowledging, giving people some credit for having had a natural COVID infection? Should we consider them fully vaccinated? Personally, yes, I think we should consider them fully vaccinated within a certain time frame, right? So if you have had a verifiable COVID infection, that should be considered a vaccine equivalent for a certain number of months after your infection, right? That's my personal feeling. How are we going to verify that for school-age children? Are we going to take the parents' word for it that they had COVID? Are we going to require a COVID test within, the last 3 months that shows positive COVID?
I think the research is leading towards, at least the peer-reviewed research that I looked at is tending towards that immunity is lasting longer in a natural infection, up to 12 months in some cases.
Maybe I'd say the data is kind of out on that, as opposed to vaccine-induced immunity. Hard to say. Yeah, I haven't. The thing about some of these studies is they do one study, and it may be even a really well-designed study, and it may show amazing statistical significance, but it's only one study, right? So the key thing in medicine is that I want to see that repeated by other third parties and groups, different populations, different places in the world, right? So yeah, it may end up that it is stronger and longer lasting, but there's no reason mechanistically that it should be, at least immunologically, right? So it wouldn't make sense mechanistically, but it may still be the case. I think we'll have more answers to that, in coming years. But I think it should be considered a vaccine surrogate. I think if you've had a natural immunity, we should find a way to give people credit for that if they really don't want to get the vaccine. But the problem is that the easiest way to provide protection for the community right now, and the most verifiable way, is for people to show their vaccine card, right? Show proof of vaccine if they want to go to school. And that's probably why they're focusing on this, because it's going to be harder to verify that somebody's had a COVID, natural COVID infection, because a lot of people don't end up going and getting tested, right? A lot of people don't go and get a lab test. So, and how long does that last for? Yeah, hard to say, but it's a really good point. I think we're not giving enough credit to natural immunity provided by an actual infection from COVID.
Some questions here in the chat are along those lines in terms of alternative interventions or treatment. Dr. Stutz, for example, infusions. If there are other things available, again, we're coming back to why the vaccine, why?
Oh, sorry, is there a question there?
Well, I suppose if you could comment, or question is having to do with alternative regimens. So why the vaccine? Could individuals choose? Could they do an alternative method?
I mean, they can do whatever method they want to, right? But if they want to go to school, then they're going to be required to get a vaccine. So there are many, therapies out there for COVID. Some of them have data behind them. Some of them don't. Some of them have limited data. But yeah, it's really hard to know what to say there. There are other drugs on the horizon that have really good efficacy that, so in preliminary data, there's some antiviral drugs on the horizon that have really good preliminary data against COVID. I'd like to see that data. I'd like to see those drugs, come to market, something that we can really trust. Alternative therapies, I don't know what we're talking about, like vitamins and exercise. Those are always.
Yeah. right? Always good choices for everything. I think it has to do with an infusion. Let me try to find the specific name. I'm going to pronounce it wrong. My Latin isn't great. Is it Regeneron or Regeneron?
Regeneron, yeah. Yeah, so monoclonal antibody therapy, what is that? That's not an alternative therapy. That's mainstream therapy. That I think the president had it, right? For Regeneron, when President Trump was infected, I think that's what he had, monoclonal antibody therapy, right? Those are antibodies that have already been developed, in a lab against COVID. It's trying to mimic what your body is doing when it gets a vaccine, right? Or when it encounters actual COVID, it generates antibodies to fight against the virus. So you're just being given the antibodies, which are protein, intravenously or subcutaneously, if you've been diagnosed with COVID. And sometimes even before you've been diagnosed with COVID, even if you had a significant exposure, they've been providing people. So yeah, that's a mainstream therapy, and it does show efficacy for prevention of hospitalization, morbidity, and mortality in COVID.
Great. So we're at 10:46. Dr. Stutz, thank you so much for your generosity of time. A lot of, I think the final question here, although there are still numerous questions, and hopefully individuals will continue to engage in discourse and have opportunities to talk through a lot of the concerns that keep surfacing one way or the other. It sounded like earlier I heard you say maybe a little bit lower. I'm not sure, so I'm going to check back with you. Did you say that you are not in favor at this time of vaccinating the youngest children, or not in favor?
Well, not being in favor and not recommending it are two different things, right? So I can't recommend it because I haven't seen any of the data right now. Am I going to be in favor of it? I probably will be. I can tell you that I'm just telling you from a experienced physician's perspective, from my gut feel, knowing how mRNA works, knowing that the long-term side effects of these vaccines are likely to be very low, knowing how immunology works, understanding how these things work, having studied this for years and years, I feel that they're going to be safe. I feel that I'm eventually going to be recommending them for kids. If it was approved for kids right now, I would give it to my own kids. So, I'm telling you without telling you that, yeah, that's probably what I'm going to be recommending. I have a gut feeling that these things are going to be safe and effective, as they've been shown to be in adults. And even though there are side effects, even though there are deadly side effects in some people have a terrible reaction to the vaccine. But the problem is that more people have a terrible reaction to COVID, right? It's just a risk versus reward ratio, right? You're just trading one higher risk for one lower risk. You're still taking a risk when you get the vaccine. You're just taking a much lower risk. You're trading in your higher risk for a much lower risk. So I'm likely to recommend it. The data shows that it's good, and I feel that my gut tells me that they're probably going to be safe in kids just like they are in adults. What do you got to say, Courtney?
Yeah, well, I think our community really appreciates hearing that you would get the vaccination for your child, for your own kiddo in the room there.
If I see the vaccine data and it's favorable, I'm probably going to try and get one for my kids.
Great. Okay. Well, thank you, everybody. Thank you, Dr. Stutz. Gingerly, any final comments or words?
No, but thank you, everybody who is in attendance and took the time, especially staying late. Thank you, Dr. Stutz and Micheline and Julie. Really appreciate the collaboration on this.
Yeah, I would also say, I'm sure there's hundreds more questions, and please feel free to contact me or send the organizers here your questions, and I'll do my best to answer them. I'm not going to attack you if you have an opinion that's different than mine. I know I'm very forceful in my explanations of things, and I'm very vociferous about this stuff. I'm not going to attack you. Everyone's opinion, they have a right to it. I just really strongly believe that this is the way through the pandemic. We worked for a year and a half to come up with these solutions. to get us out of this situation. And this is what science has provided to us. Is it 100% safe? No, it is not 100% safe, what we're doing. Medicine never is, right? It's a very difficult, very gray area. And all we can do is do our best to recommend what's best for most people. And so, you know, I really just strongly encourage people to send me your questions, even if you think they're ridiculous. You know, I will do my best to answer them, and I won't attack you, okay?
All right, well, thank you again, Dr. Stutz. You were an incredible partner last year, especially. We remained open every single day of our school year. You were always available to our district, and received all the questions and comments, and I appreciated partnering with you. We look forward to that continuously and ongoing, and perhaps there's an opportunity to do a follow-up. So thank you to Ginger Lee and Julie here at the district office. Thank you for getting this all set up. I'll admit I was a little bit of a novice to manage all of this today, but this is the result of great teamwork. So thank you, everybody. Thank you, students, for attending. It was great to see you out there. Have a great rest of the day. Bye now.
Thank you.